Hi there, my name's Damien. I'm the Head of Service of the Children's Emergency Department at the Leicester Royal Infirmary. There have been some great talks today. A lot of them have focused on particular subjects or particular parts of our specialty, particular disciplines, particular conditions. I'd like to take a slightly broader view and just look at decision-making in its totality and the mistakes that we can make in children's emergency care and some of the things that we might be able to think about to stop us making mistakes, in particular those ones that might relate to patient harm or a poor patient outcome. I do want to start with something that I've often shared in presentations and some of you may have seen before. This is a picture by Luc Fildes. It's at the turn of the century. It's called The Doctor. And what your eyes are immediately drawn to is the stereotypical picture of a white male with a beard looking at a child who is unwell. Your eyes may then notice the figures in the back of the room, the parents, and it might take you a bit longer to see that the mother of, or presumed mother of this child, who is kind of crying on the table. And I use this to remind me all the time that we are part of a bigger picture in pediatrics. It's about the clinician, it's about the child, but the parents and carers have a huge role to play. And yes, it's a bit glib in pediatric talks to say always think about the parents, but I will, as we go through this talk, highlight where parents can be a huge advantage, but actually the way that we speak and the way that we use language doesn't always make it easy for them. And again, that's how mistakes can happen. Now, this is a Mike Tyson quote. I quite like this. It's easy on a shift to think about, okay, I have a plan for dealing with this. I have a plan for dealing with that. And then there's this curveball that comes outside from absolutely nowhere and catches everyone by surprise. And being aware of that's quite important. So we're going to play a little, some games to begin with. Some of you may have seen me do this type of thing before. I try and update this slide deck all the time. So this is a brand new picture, particularly for this session. And what you need to do is find the cat. Now, some of you may have found the cat already. Some of you, it might take a bit longer. But the important thing is that think about, maybe stick in the chat now, have you seen the cat? Start putting pressure on those people who haven't seen the cat. So in some way they feel, oh, this is a bit uncomfortable. Maybe celebrate the fact that you've seen the cat. Okay, so I've given you a good 20 seconds now, and there is the cat. It's in the top right-hand corner. Why am I doing this? Well, the point of this process is once you have seen the cat and you've seen this particular slide, you're always going to find the cat almost immediately. Even when you knew when you first looked at it, you couldn't see it. And that retrospective scope is quite important. But the point of the process is there are things that take us time to see, but once we've seen, it's really obvious. And to put this into a tangible medical example, I'm sure some of you have seen this before, but this is from a published paper. It was done with a load of radiologists, and a number of CT segments were shown to these radiologists, and they were asked what the abnormality was. Now, you will be drawn to the fact that in this person's chest, there is a gorilla. But about, I think, 23% of the radiologists did not see the gorilla in this CT slice. Why didn't they? Well, because they're not looking for gorillas. They're looking at the chest markings, and their eyes have kind of glossed over them. And this is a really important function in children, especially when you're practicing pediatric emergency care, is the majority of children that we see are relatively well. Their acuity is low, and it's very easy to go through the motions when you're seeing the same thing again and again and again. So you're expecting and you're looking for something, and when you don't see it, it catches you out. So there is the gorilla, if you've not seen it by now. And this is called inattentional blindness. So we're often anxious at the beginning of the shift. Anxiety is good. I get anxious on a shift. It keeps me pumped up. It gets my adrenaline going. The problem is when that anxiety turns into cognitive overload. And this is what's happened in overcrowded departments, when we have too many patients, not enough staff, nowhere to put our patients. You get overloaded, and then you just stop seeing things. Stuff that's right in front of you, you can't find it. And that's when we have performance concerns. And this is really harsh. It happens in adult and pediatric practice, is that mistakes are made, and they're not made because people are bad doctors or they don't care about their patients. It's because they sometimes literally can't see what's in front of them. And then we have an additional problem. Perhaps this is a bit more unique to medicine. I was trying to teach my 6-year-old daughter how to play Guess Who. So this is a game where you have to kind of call out your character's different eye colors, different hair colors. Do they have a beard or not? I spend a lot of time with with Isla, who's 6 years old, as I said, and 20 minutes or so it takes me to explain all the rules. So I go, okay, Isla, you go first. And she goes, is it Anne? And I look at my card. Yes, it was Anne. Yes, she jumps up and she runs off, and she's never played Guess Who again, because she believes that actually she's good at it. What is the point of playing a game that you can just win first time? And there's lots of debate about, is this the Drowning Cougar curve? Did they actually call it the Drowning Cougar? Did Drowning or Cougar actually mention this? But Nassim Taleb, who wrote a book called The Black Swan, calls it arrogance in the face of competence. And I quite like this as a term. And basically it's saying there's as you start in any particular discipline or field, your confidence outweighs your experience. And then something bad happens, you realize you're not as good as you think you are, and then you spend your rest of your career trying to get up to that point. So we've got two issues now in children's emergency care. We've got this concept of inattentional blindness, but also for some people, they're better than they think they are, and then that makes the inattentional blindness perhaps even worse. The reason in children and children's emergency care that this doesn't cause absolute catastrophe all the time is because basically not that many children get really unwell. And this original quote actually did say the incompetent. I think that's a bit hard, but inconsistency is a real problem that we have in all aspects of medicine. And just to prove to you that actually it is really easy to make mistakes at scale in terms of what you see. This is from a paper called the Episode Study, and a lot of emergency departments in the UK, also in Europe, collected data during and just after the COVID pandemic. And what you'll see is on the left-hand side is the percentage admission rates of children in emergency departments across Europe. And your eyes are drawn to the fact that we admitted a greater percentage of the total in April 2020 compared to previous years. And I think people working in emergency departments at the time may have felt that increase. But if you look at raw numbers of hospital admissions, they were much lower. And this is a real challenge in terms of perceptual problems. And there's all sorts of things about, we had sicker children during COVID, people were presenting late. But actually, a lot of this was actually, yes, admissions were higher, but presentations were much lower. And it takes our brains a bit of time to pull those apart. So what I want to do now is speak about a few particular conditions, but how biases into play with that. So let's take Trevor. He's 51 days old, no risk factors at birth. His temperature is 38.7 degrees. Now, what is his risk of having a serious bacterial infection? And if you look across a load of papers, it's around 9 to 10%. Last good data set was from Nate Cooperman in 2019. Now, if you ask most pediatricians or kind of emergency clinicians who do a lot of pediatrics, spend a lot of time looking after infants, they will make a gestalt judgment about whether a young infant has sepsis or not. What's interesting is that they're actually not that good at doing it. And from the big study that was done in the PECAN network in 2019, the clinical suspicion of SBI, which was asked of the clinicians as this prospective observational study took place, bore no resemblance at all to the chance of this infant actually having a positive infection. And that's why there's this unique feature of febrile infants, is that this 9 to 10% is completely independent of how they look. Literally, if you are less than 3 months old and you have a temperature on the basis of that alone, your risk of an infection goes up. It's around 10%, and I can't think of any other condition in pediatric emergency care, or in fact in any care in medicine, that has those particular odds. Now, another thing that is kind of common at the moment is respiratory disease. So let's think about the little infant who presents with bronchiolitis. Assessment nurse looks at this child and goes, "Oh, actually, I think someone needs to see them." The child has been snotty, bit of respiratory distress, unwell for a couple of days, and the nurse is worried because their saturations are low. They've entirely appropriately highlighted this patient for early review. Some oxygen is given, and the child gets a little bit better. And so what happens is traditionally we admit patients who are in oxygen. So doctor phones up to the ward, "Look, we've got this child, they've got bronchiolitis, they need a bit of help feeding, a bit of oxygen. I'm sure they'll get better soon." And what happens is at 2 o'clock in the morning, this child completely collapses because it wasn't bronchiolitis at all. In fact, it was a cardiac defect, and this child was just in an early stage of their duct closing, and eventually they collapse. Whose fault is that? Well, it's difficult to know because there were so many biases pushing you towards a particular point of view. And when you go back, should someone have listened to the heart properly, done the femoral pulses? Yes, they should have had. But again, you've got a busy, overcrowded department. You're making snap judgments. That inattentional blindness is at play again. These cognitive biases are everywhere. I'm not going to talk about them all, but what I would recommend that you do is that you Google 20 cognitive biases that screw up your decisions, because there's a really nice PDF and paper that goes with that, and it's just worth having a look through. But to be clear, it's really frustrating. I can tell you now that no one has done a study that has shown that predicting cognitive biases stops those cognitive biases occurring. So a few more clinical conundrums for you. So I've just talked about a febrile infant, but what about the temperature? If I had just shown Trevor having a temperature of 38.1 degrees, but then I give you a temperature of 37.9 degrees, does that change what you do? And it probably shouldn't, because how can a bacterium or a virus know the difference between 0.1 of 0.2 of degree? If you look at a thermometer, they're not designed to be more accurate than 0.2 degrees centigrade. But yes, we'll react more to the 38.1 than the 37.9. And this is a great slide from Rick Boddy, Professor of Emergency Medicine in Manchester. When does negative become positive? There's so much. When does your CRP matter? Is it 9 to 10, 11 to 12, 49 to 51, 99 to 101? Where is your predefined limit? And this is where kind of Bayes' theorem comes into play. You really need to be thinking about, when you're doing a test, what is the value that I'm going to act on that's going to make a difference? And then the other thing, and I love this quote from my colleague, Dr. Gareth Lewis, about the child who gets some saturations. Saturations aren't picking up, so someone changes the probe. They then change the body part that probe is going on. They go from the foot, and then they go to the hand. Then they decide the machine isn't working, and it takes 10 minutes for someone to realize, actually, it's the child's SATs are actually 66%. And I jest a bit, but think about not only the tests that you're doing, but actually the equipment that we use tests on is fallible sometimes, but also we don't also trust our better judgment. Now, of the moment, Group A strep, child with tonsillitis. What do you do with this? What is your threshold for treating? If we go back a couple of years pre-COVID, Royal Children's Hospital in Melbourne have not been treating tonsillitis for some time. The only time they give it is to their specific high-risk groups, Aboriginals, Torres Strait Highlanders, who have a clear outcome issue if they do get a streptococcal infection. But by and large, the rest of the population will get better, and you don't really need to treat it at all. People are really uncomfortable with that. But why are we treating tonsillitis? Well, maybe we want to protect against abscess. You need to treat 4,000 patients before that becomes relevant. So I don't think it's a great thing to do. Now, the challenge is at the current moment, what we would like to be doing is suggesting that you don't treat infections, but it's almost impossible when we have a higher than normal incidence of death from eye gas. And we're in a difficult sphere of practice in paediatric emergency care. As of today, I'm recording this on the 13th of January. Yes, it looks like our incidence of invasive disease is falling, but not enough to change our guidance. And the guidance at the moment is that we should have a slightly lower threshold for treating, definitely treat scarlet fever, that's really important, but also for treating what appears to be a streptococcal sore throat. And maybe we can talk about a bit more in infections. But just to really hammer home the point about how often antibiotics are actually needed, the Caput study looked at different doses, low and high, and different durations, long and short of antibiotics. So a 3-day versus 7-day course, a low and a high dose course, compared those 4 possibilities. And what we found was that there was virtually no difference at all, either in the lower or higher strength or longer or shorter duration. But what you'll see is that resolution of cough took about, in 50% of children, nearly 2 weeks. And so one of the things that we probably don't need to be giving is antibiotics in standard pneumonia. And there is an RCT in America happening of just that, just not giving antibiotics. But what we do need to be doing is telling parents that the cough is going to last for a long time. And what's interesting is that we need to think about this a bit further, because it wasn't clear after the study what that importance was. And we need to do a lot more work with families at understanding outcomes of disease. What is most important to them? Because if we don't have those conversations, we presume they want the antibiotics, we presume they want to be admitted, but that might not be the case. And that shared decision-making is absolutely vital. And this is one of my big bugbears, is that we often start these traffic light systems in telling parents what the problem is with the red. Let's tell you the worst possible things that can happen with your child, when I prefer to have it, let's start with the best possible things. What are the things that you can look at your child, you can go, yes, that's okay, there's nothing wrong with my child, I can stay at home, rather than scaring them to begin with. And the reason for that, as I've tried to encapsulate in this slide, is that there is this problem when we start talking a traffic light language compared to the parents. So if you go to your patient, you're green on the nice traffic light score, you're safe for discharge, but that child still has symptoms. You've not addressed the parental concern. Amber criteria sometimes mean a bit of evaluation, but for the parent, that might be the most unwell they've ever seen that child. And so we need to balance the language that we're using in terms of risk with the parent's understanding of risk. And we are dreadful at doing that. And that buys into this agenda. From our point of view, we just want to make sure that we don't need to do anything instantly. We like having a robust diagnosis. And what we want to do is rule out the worst things, but we don't care whether it's a viral illness or not, as long as we've confirmed it's not a bacteria that could be invasive. Parents are similar, but it's not exactly the same. They want relief of pain. They want certainty that the illness will resolve, which we can't give them. And we want certainty there'll be no long-term consequences, which we also can't give them. And that's why we safety net. And that dissonance is important, because sometimes that dissonance results in harm because we've not given the parent the right information, and sometimes it's a safeguarding concern. And so this kind of graph highlights this balance between high risk of illness and high concern in the clinician as well, low risk on both sides. But those 2 other boxes are where we really need to start thinking and start understanding what we can do to ensure that there isn't going to be harm from the parent ignoring or going away from the consultation thinking that nothing will ever be wrong again, but also underplaying some of the symptoms or overplaying some of the symptoms so that they come back within 6 hours or so. And I recently, with a GP, published this graphical representation. It's not perfect, I get that. But what we want to do is look at those things where we can make a difference in our safety net. So if we bring people back too early, that's inefficient. If we bring them back too late, that's catastrophic. So it's thinking about, okay, what are the features of illness that are going to make a difference to this child? And my biggest bugbear to my juniors is they see someone with DMV and say, come back if your child continues vomiting. That is rubbish safety net advice. If you've got diarrhea and vomiting, you're going to continue to vomit. That will happen. I'm not interested in the vomiting. I'm interested in the dehydration that comes with vomiting. So your safety netting needs to be about hydration, not the symptom that you presented with. And then just to finish off, I want people to think about kind of a diagnostic trajectory. So through time, we've always been frustrated that lots of children are presenting to emergency departments. And then all of a sudden, children stop presenting to emergency departments. And what did pediatricians in particular do? I don't think the emergency clinician group did this, but pediatricians started going, where have all the children come? Come back to us, come back to us. And that was really harsh on parents. They get criticized for coming too much, and then they get criticized for not coming at all. And then there was all this talk of children with delayed presentations and coming to harm. And it begs the question, does presenting earlier to hospital actually mean you'll be diagnosed with sepsis or diabetes any earlier? And then it really focused my mind on what is a delayed presentation. And there were two competing bits of research during COVID. One, a survey of pediatricians where 50% of them said they'd seen harm from a delayed presentation due to parents being anxious about COVID. I did a prospective observational study, and what we found was that the harm from a delayed presentation in over 1,500 attendances was absolutely minuscule. And how do you marry those up? But it's about perception. It's about perception of risk. And I've already tried to explain through that episode study at the beginning, we actually perceive risk really badly. I know parents do, but also clinicians. And again, something that we need to think about. What's the difference between a late presentation? So diabetic ketoacidosis often presents late. It's characteristic of that condition. The parents don't notice the weight loss. They don't notice. They think that the fluid volume increase is the urine output increase is to do with drinking lots of fluid rather than vice versa. So that's classic. Missed is, I suppose, when you have actually missed a diagnosis. If a child presents and they have been urinating a lot and they say they're thirsty and you don't do a sugar, that's a misdiagnosis if that child comes back with diabetes. But delayed is much more difficult. When does this sepsis conundrum move from being something you could have acted on to something you definitely should have done? We have had some tragic cases in the last couple of months with children who have presented viral illness, a bit snotty, and then they've had invasive group A streptococcus. Was their presentation delayed because the parents didn't bring them in 6 or 12 hours earlier than they should have done? We will never know. And we need more work on that. And this challenge in terms of knowing where a child is in their state of illness is of real interest to me, because I'm doing a lot of work on the National Pews programme. And let's take children who have simple asthma. Now, if you go to your primary care, you go to your GP, and you don't need any intervention, just some safety netting, that's green, okay, that nothing needed. Now, the PICU equivalent of no immediate intervention needed is a stably ventilated asthmatic. They're completely different patients in terms of their acuity, but they're the same in terms of their level of risk. We can do the same thing with bronchiolitis. So in primary care, that might be someone who's referred in for hydration advice. A similar patient on the ward might be someone with slightly increasing oxygen requirements. And I can fill this whole table up. But what it collates to is the fact that across systems, from the moment the child becomes unwell in the parent's home all the way to coming into PICU, we have these stratospheres of severity that can be color-coded. But the point being is that where you are in the system really does influence your risk. And you need to think about that when you're thinking about a GP referring you someone in, or when you're referring onto the ward. And then the one thing I've not discussed at all in this talk is mental health, which is probably a talk in its own right. But I just wanted to highlight that some of the risks of mental health are probably no different than some of the physical risks that I've talked about before. What is it that makes you decide to make referrals? When do you judge that someone's taken an overdose? Do you believe them when they say they've only taken 10 paracetamol? When is that threshold for intervening? When that child leaves without being seen by the CAMS team, how hard do you work to bring them back into the department? And these are all really difficult decisions, but they are all based on your understanding of risk and the attribution of bias. And you can understand that when you're really busy and you've got a lot on your plate and there's a couple of febrile infants, it's the mental health patients that sometimes get left behind or left in the corner, and that's when real serious harm can happen. So thank you all for the hard work you do in your department. It is hugely appreciated. The last couple of years have been horrendously tough, and I really wanted to acknowledge that on behalf of the Royal College of Emergency Medicine. Thank you all.